Thank you. I'm assuming I need to be unmuted for everybody to hear her. Is that correct?
Yeah. He represents all the types of oxygen therapy that we can possibly. I know, but I thought he was a good, like, disaster example of what can happen.
Is there a picture of the back of my car?
No, I couldn't find it, but, when people breed bulldogs, this is what they look like. So, all right, let's go ahead and get started. We'll start with the first case, which is Rufus.
Can you hear Dr. Bailin okay online?
He's a 2-year-old male neutered bulldog. He went for.
Yes, we can hear fine.
Thank you.
Noon. And he's presenting for respiratory distress. So, I want everybody to picture him in your mind, could be Bumble. What does he sound like? That's exactly it. I love
Very
that.
good.
Yeah, so they're like,
For all this.
if you had to categorize where you were hearing the most of his effort, would it be upper, lower, both? Like upper. I like purely upper. All right, so before we go into a little bit more of that, let's talk about localizing airway disease. I thought it would be a nice thing just to kind of review pulmonary at the very most, like zoomed back thing. So pulmonary anatomy in dogs and cats, just so that we're all on the same page. Dogs and cats have the left side of their lungs and the right side of the lungs. The left side has 2 lobes, the cranial and the caudal, and then there's the cranial of the cranial lobe, and then the caudal portion of the cranial lobe, and then the caudal lobe on the left. And then the right has the cranial, middle, caudal, and accessory lobes. We tend to see things like aspiration pneumonia more in the right middle or the cranial, predominantly the right middle, mostly because of the bronchial branching. When we're thinking about like cardiogenic pulmonary edema or non-cardiogenic pulmonary edema, it tends to be in the caudodorsal aspect. Infectious pneumonia also can sometimes right out there or in the cranial dorsal, and then an aspiration that tends to be more in the cranioventral or right middle. So what I think is really important when we start looking at these cases is trying to identify where in the respiratory portion you're looking, because that helps identify it helps rule in or out certain disease processes. So the way that I like to remember this is when I was in vet school, we had a professor that told us all to hold our noses and then try to breathe in versus breathe out, and to see which one was harder to do. So if we hold our noses and breathe in, we can breathe in with a lot of difficulty, but we can breathe out with pretty easy, or with not a lot of difficulty. So usually when an animal presents in inspiratory distress, it points towards an issue with the upper respiratory tree. Whereas excretory distress tends to be an issue more with the lower airways, so lungs beyond the thoracic inlet, and the trachea beyond the thoracic inlet as well. And then there's these really kind of interesting cases of paradoxical breathing, and there's paradoxical breathing and there's flail chest. And this actually has to do a lot with how we breathe, the mechanics of breathing, in order to try to understand paradoxical breathing. So normally when we breathe in because we're generating negative pressure by the movement of our musculature in our rib cage and diaphragm. So as we're breathing in, what's actually generating that breath is that we are contracting our intercostal muscles, we are contracting our diaphragm, and that actually pulls the lungs open by their connection to the pleural lining, and opens up the lungs that way. And then when we breathe out, there's this elastic reflow of the chest where all of those muscles relax and pushes the air back. When you have paradoxical breathing, the connection between the video thing.
No, you're fine. It's on here.
That is also really hairy. But so the paradoxical breathing is actually an issue with the chest space itself, the pleural space. So, so what happens is that connection between the body wall and the lungs is no longer patent. So something is getting in the way of that normal respiratory mechanic. And because of that, even though the body is trying to generate that negative pressure through contraction of the muscles, it's not, what's it called? Being related to the lungs. And so it causes this extreme effort to try to get even the least amount of air into the lung space. And in doing so, all of the rest of the muscles of the body have to work. And so paradoxical breathing is actually where you get extreme muscular activation with only a little bit of chest wall movement and really dramatic movement of the abdomen. And so it's these cases that come in that are like trying to breathe in, and that, especially in cats, usually points to some issue in the pleural space. So not an issue with the lungs, not necessarily an issue with the trachea, an issue with the thoracic cavity. And then there's a really special one called flail chest, which is paradoxical because the rib cage itself is discontinuous. So you have to have a fracture of the ribs, of several ribs, both at the top of the ribs and the bottom of the ribs, so that they are no longer in communication with each other. You could also have a really large rent in one of the muscles in that area, but and that causes during inspiration where all of those muscles are trying to contract in and move the chest wall out, because that chest wall is no longer intact. The portion of it that is broken moves in with the lungs. Basically, it's staying put. And then when they move out, it pouches out because the lungs are being pushed back out. So this is a really important thing to notice when you're talking about like hit by cars or blunt force traumas, things like that. Interestingly, with flail chest, it's not necessarily that the chest wall is broken that causes them to be in respiratory distress. It's more of the pain of those fractures and whatever injury to the lower airways has occurred. So usually there's some degree of pulmonary contusion that comes with it, and that leads them to respiratory distress. The fractures themselves aren't enough to break down the mechanics of breathing in these cases. So flail chest. So we have this bulldog come in. It's breathing like that. We do. Okay, so sedation, catheter, put a tube in it. All of those are really good things. What are we doing when we're sedating it? What are we doing when we're sedating it? So yes, in some degree we are. That's why we try to choose medications that are going to be less of a respiratory depressant. We don't want to take away their drive of breathing. But what else are we doing? So you could give oxygen. I think whenever you have an animal that comes in respiratory distress, giving them the benefit of the doubt that they may need oxygen is a really important thing. So some degree of flow by. The sedation in and of itself is taking away the anxiety of being in this kind of crisis state. So inflammation breeds more inflammation. The more that they can't breathe, the more anxious they get, the more they try to breathe, the more inflammation they develop. That cycle just repeats. So sedation in itself is trying to break that cycle, or trying to break the anxiety associated with that cycle. The intubation is allowing us to get a patent airway, right? So he's obviously breathing with significant inspiratory effort. We can hear that with the stertor and the stridor. So stertor is that kind of snoring noise that bulldogs make. Stridor is this high-pitched noise coming through these clamped down airways. It's this whistle, almost like a wheeze if it were in the lower airways. We actually had a really great example of this. I don't know, who knows Nathan upstairs? Is he still upstairs?
Rocking no tricks since yesterday.
That's really, that's awesome. So Nathan came in with Sturter, but then right before he tried to completely collapse, he had the most amazing Strider that was this very high pitched whistle that was going through his larynx, which was kind of like the minute that you hear that and see that, you can point to say, hey, this dog is an upper respiratory crisis. So intubation is absolutely the thing. Now, usually when we're intubating and bypassing the upper airways, what do you guys remember starts happening with these dogs in terms of their stability? What do they start doing? It's not the best word of question, I apologize. So usually these dogs, let me kind of set the stage here. They've come in, they're hyperthermic, they're tachycardic, they're tachypnic. You intubate them, you've sedated them. Heart rate starts going out, blood pressure starts normalizing, temperature starts improving. Oftentimes we're going to hook up a pulse ox to them. And how many times have you guys hooked up the pulse ox and it's reading at 100% as soon as you bypass the upper airways? 99, 98%. Yeah, with some degree of frequency, right? Because the issue is in the upper respiratory tract. So by intubating, you're getting rid of the issue. Now, oftentimes, there's two ways that we can go about then trying to further like getting them off the table. One is the wait and see approach. So keep them intubated for 1 to 3, sometimes longer hours and slowly extubate them. Versus just go straight for a tracheostomy. Do you know what we're doing when we're waiting the like 1 to 5 hours with this? Yeah. Trying to get the steroid on board, we've broken the anxiety cycle. Hopefully we're trying to bring that inflammation down. It does work in a good majority of these cases. In some cases, you can kind of say, especially as you're trying to intubate the inflammation, there's not a chance that this is going to improve in the next 1 to 5 hours. And those are the animals that will convert to trach on, which is part of the reason why Nathan got intubated and then was like, you're getting a trach, because his airways were horrific. So I thought that it might be nice to kind of see what we're doing when we are doing the tracheostomy. So we're making a cut down, we're isolating the trachea itself, usually about 4 to 5 tracheal rings below the, I'm not a surgeon, so I don't remember what this is. This, the larynx. Nailed it. And then you put a stay suture above and below the ring that you're going to intersect, or the intertracheal space between the 2 rings that you're going to transect, and then just cutting a hole. And that hole can't be more than, I think it's like 50% of the circumference of the trachea, or else you just cut off the trachea, which is bad. It has happened. I haven't done it, but it's not great. And so then you insert your tracheostomy tube in there. So here, this actually goes do. So you insert your tracheostomy tube. There's this inner kind of cannula that is not patent, but has this kind of nub at the end of it that allows you to guide it in. And then you take that out and replace it with an inner cannula that is patent, and that's what stays, like both the inner and the outer cannula stay in there. And then you tie it in place around their neck. Couple of things with trach care. The trachea has to stay moist, or else it starts producing a lot of secretions. And the more that you irritate the trachea, the more secretions it'll produce. So there's this balance between cleaning this site and removing this tracheostomy tube and suctioning it to try to make sure that it's staying clean, but also not doing it so frequently that it produces more boogers and then gets itself all caught up. And so usually if the dog or cats tend to produce a lot of mucus in their tracheostomies or pain in the butt. But if the dog is relatively clean in there and not producing a lot of boogers, it won't actually suction very frequently, because bringing that suction tip in there and having it scrape along the trachea on the way down can cause a lot of irritation. But nebulizing and then just removing that removing the inner cannula, we usually do it every 4 hours until they start to produce secretions is typically sufficient. So that's what it looks like, what we're looking at. It was all ready to do Nathan's, and then Retalix swooped in and saved the day, which was probably good for Nathan. All right, so this is Isabella Francesca de Minuar, I named her. So she is a 5-year-old indoor-outdoor cat, and she comes in. Let's see if I can get this to work. Before I do, oops, okay, well, you guys are gonna see it now, but before I do, does anybody have any questions on upper airway bulldogs? There's like 2 seconds of excitement with them, and then it's like 10 days of hell.
Sounds about right. I'm triggered. We do have cats now.
Yeah, let's go to cats. Okay, so I don't condone how they're treating this cat. But this is what Isabella Francesca de Minuar says. Oh, and the answer is on the thing. Okay. So look, that's in, out, in, out. When it comes around to the side, watch her abdomen while she's inhaling. And you can see that massive, that massive effort that's going in, and then also the very minimal movement of her chest wall and this dramatic movement of her abdominal wall. And then they're just kind of sitting there filming her slowly die. So
This
Oh, dear.
is how to get in shape fast.
oh dear. Okay. This isn't my computer, so you guys can't see my history. So so that was paradoxical breathing, right? Paradoxical breathing, what does that point to? What? Pleural effusion, so an issue in the thoracic space, right? So not necessarily the lungs, not necessarily the trachea or the upper airways. That is kind of pleural space disease in a nutshell. Excellent. So couple of other things that you can tell if you were physicaling this animal, besides the really dramatic paradoxical changes. If you were to listen to this pet, you might hear a differential in the lower portion of the chest and the upper portion of the chest. So if it had pleural effusion, you would hear a dullness or an absence of chest sounds ventrally, and then harsher or normal chest sounds dorsally. If it were air, you'd hear the opposite, so absent lung sounds dorsally, harsh lung sounds ventrally, just from the lungs are either floating on the liquid or they are being compressed by the air. The other thing that I think is really fun in cats is pressing on their chest wall. So usually cats have a very pliant chest wall. You can press on it, you can feel it kind of move, you may even feel the heartbeat. When they have pleural space disease, the compliance of their chest is greatly diminished. So it feels really firm on there. And that's another clue in that you need to be looking more into the chest space itself, which is really important when you're trying to think about how you're going to stabilize this patient. Asthmatics actually also have really decreased thoracic compliance because they've got air trapping and hyperinflation of the lungs. But you can't really feel it on dogs. Cats, next time one of these comes in with like heart failure, press on their chest and see if you can tell the difference. Okay. Oops. Okay, so we said pleural effusion. I think I fixed it. Yeah, it did. I don't know how. So, pleural effusion. For those of us that are taking x-rays, this is what it looks like. You can see obviously the lungs well inflated here, and then there's this kind of, what's it called? Summation. So you can't see the cardiac silhouette. There's this kind of fat fluid attenuation. I don't know if that's the right word, but opacity, the x-rays in the lungs. And then if you were to fast scan it, this is the heart, little tiny pieces of lung, and all of this black is fluid. So just as an aside, it would be really great if we never diagnosed pleural effusion or pneumothorax by x-rays, just like in general. These patients that come in are usually pretty unstable. If they have significant enough accumulation of fluid or air in the chest space, you should be able to find it on your physical exam, either by listening to it with hearing the differential, feeling that chest wall compliance, or just as part of the general physical exam of being a doctor in the 2020s, doing a quick fast scan. It can be really dangerous taking these guys down to Radland. This is more of a soapbox for the doctors and less of one for the nurses, but just like, if you think that there's an issue with the chest space, by all means, just have the probe ready for the doctor to come in and scan it, so that you can actually stabilize it. Speaking of, how would you recommend that we stabilize Isabella Francesca anymore? Okay, yeah, sedate and tap, right? Oh, actually, that was the next thing. Sedate and tap. All right, so I feel like everybody's set up for a thoracocentesis before. Super easy. Syringe, stopcock, three-way, and then an extension with a needle. Cats, sometimes you can get away with butterflies, which you ideally don't want to do is lacerate a lung lobe on the way in. And so having control of the needle and knowing the depth of the chest wall when you're going in is kind of important, which is why the fast scan can be kind of a helpful little tool, because if you look back on here, there's these numbers along the side of the V for the ultrasound, and that tells you your depth. And so if you have like 1 and then lungs, you probably shouldn't grab a large angiocath to stab the chest. So that can help with the thing. The other thing is that based on where you're hearing the differential or where you're seeing fluid versus air, will tell you which part, like whether you go dorsally or whether you go ventrally. You usually will tap somewhere between the 7th and 9th rib space if you're trying to hit the lungs. Nope, if you're trying to hit the chest. If you're trying to hit the heart, then it's the 4th and 5th rib space. Okay, so we tap Francesca, we get a good like 400 mLs of really fetid fluid. Anybody know what we're looking at? What?
Fluid.
Yeah, well, so yes.
Plural fluid.
Thank you, pleural fluid. Okay, so so this is a stained slide. This is actually a real slide from a cat's chest. Couple of things that I want you to notice. These are neutrophils. Some of them are really, they get kind of angry looking when they're in nasty fluid. They get kind of clumped up like this. Yes, all of these little dots are a whole bunch of different bacteria. And there's some red cells in there, and then there's like some exploded neutrophils and proteins. There's some red cells here. This is pus and bacteria. So this is a pyothorax in a cat. Pyothoraxes are relatively common. The indoor-outdoor cat is kind of an important part, or they get into fights with their housemates. So in cats, it's predominantly caused by bite wounds, extensions of like abscesses from the lung space itself. You can see migrating foreign bodies, sometimes you can see pneumonias, but the most common in cats is gonna be a bite wound. And usually you're gonna see Pasteurella as the primary culprit. So it tends to have that kind of disgusting, strong smell. And then in dogs, it's typically more of an inhaled foreign body issue. So like out, you can actually probably see it here, but like out in California and that side of the area, there's a lot of grass on inhalation that then starts migrating. And those will come up with some pretty nasty pios. In dogs, it's usually more E. coli as the culprit bacteria in the chest. Both cats and dogs can get these really interesting infections. It's called nocardia or actinomyces. They're really beautiful bacteria actually that are this kind of filamentous, thin, long-stranded bacteria. And with nocardia, they come up with these like sulfur granules. So it's a pretty characteristic like draw or sample where you get these bright yellow caseous blobs that look kind of like curdled milk in the chest. So how do we treat pios? Got the sample, we've drained it, it's feeling a lot better. Obviously, we've got some antibiotics on board, but what's our next step? Sure, you could CT. So the CT would help identify whether there's an abscess, whether there's an obvious tracking wound. Whether there's a cancerous infected pulmonary mass, which I don't think I've seen very frequently. So this is when there's two ways to do this. You can do this with medical management, or you can do it with surgical management. Cats actually tend to do pretty darn well with medical management, all things considered. So medical management is where you shove some chest tubes in there, and keep them in for usually somewhere in the 5 to 7+ day range until their chest dries up, and you're not getting any more effusion out of it. And until you're not seeing a whole bunch of bacteria on their daily cytologies. So you could probably manage, I think, with the success rate of like 70% medical management. Dogs, you could try it. It tends to not work as well. You tend to actually have to go in and explore the chest. So either by removing the portion of the lung that's diseased or just flushing everything out and putting appropriate drain in. But this is when we're looking at chest rads, after we've put in chest tubes, this is what they should be doing. So you should be seeing them enter at like the 9th and 10th rib space, ideally dorsally. I will say, and it's noted in here, that the left chest tube is not appropriately positioned because it's going in too far cranially. Your goal is you're trying to get all of the fenestrations in the chest tube down as far as possible for the entire length of the ventral portion of the chest wall. And so when we're doing this, we're trying to like hit it up. So if this is a cat, right? This is a cat chest. If this is the top of the chest and this is the sternum, we're trying to get the chest tube here and then angle it so that it goes down basically towards the armpits. And then we're looking to make sure that on both a lateral and a VD view that we're having them enter at the right space, that they're going down appropriately and they're getting into that armpit. Have to say, a lot easier said than done. And it's my least favorite procedure because I tend to hit the lungs. In pneumos, you actually don't have to be as precise with your placement because the air will travel to the dorsal most aspect. And so you just have to get it in the chest space, as opposed to trying to hit all of it. So those are the fun parts of pios. Any questions on that?
I know they can be old. Barn buddies too, that we've seen on where they've been 2, 3, 4 years old,
Yeah,
and migrating to barn buddies. Porcupine kills from like 6 years.
yes. Porcupine, you're absolutely right. They
So-
just need to take enough time. for them.
Relevant history doesn't have to be in the last week to 2 weeks.
Very true. In fact, it's usually quite a bit longer because,
It takes enough to cause the infection.
correct, absolutely right. Yeah, so history, very important. The other thing that will kind of give you a clue, like most of the time, I feel like we see pleural effusion in cats from things like heart failure. Heart failure tends not to be febrile, whereas pyovorax does. They also tend to be kind of the like huskier cats that get the pyos. Although I did have a Sphinx that was 7 years old that came in with a chest full of flu, and I was like, this is gonna be heart failure. And he did have a bad heart, but he also had gotten bitten by his housemate and had a pyo. But
So the Sphinx have everything.
Sphinxes do have everything. Okay, this is Lady Gray. She's
Aw.
perfect. She's 12 years old. She's an angel lab. And she ate breakfast, took a nap, and then vomited, and then she presented for acute dyspnea. All right, so old lab coming in. Anybody have an idea what this would look like? What?
Our power with effort.
Oh my God, that's exactly what it is. It's gonna be larpar with aspiration pneumonia. So how might that sound? Okay, she only does bulldog. I was looking straight to you,
I know, she's
like, right? Yeah, so,
Every
what-
other Labrador in the world.
right, so couple of things. You hear that noise, and which part of it is the larpar, which part is the aspiration pneumonia? Like if you're doing that kind of full effort like that. Don't look at me like that. Which part's larpar, which part's the aspiration pneumonia? If you're looking at that animal and you're seeing that it has really significant upper airway that's inspiratory. Oh, I gave it away. So inspiratory. Yeah, so the larpar is the N. And then the hard expiratory push is going to point to probably some degree of lower airway disease as well. One of the things that's really helpful on night calls, like when I'm getting a call at night, trying to figure out what's happening with my life. If somebody tells me dog has started having respiratory distress, it looks primarily inspiratory, or it looks primarily expiratory, or it looks mixed. That in and of itself can very quickly help me decide, do I need chest x-rays? Does it need sedation? Does it need to be intubated? Just for what it's worth. All right, so gonna go on a little jaunt for a second. So I want you guys to keep larpar aspiration in your head, since you guys already like nailed that on signalment. But how do we recognize hypoxemia in animals? What is hypoxemia? Low oxygen in the blood. So there's 3 ways we might be able to tell that an animal is hypoxemic in the ER on triage.
membrane.
Okay, purple gums, muddy gums. What's that word called? Yeah, cyanosis. All right, so cyanosis. Cool, absolutely. Physical exam wise, they look like they're in distress. It could be inspiratory or expiratory, depending on what we see. What else? What other tools are we going to have to our, okay, pulse ox and an arc gas. All right, excellent. Let's talk a little bit about pulse oxes. So what?
Like I said, they never work.
Right, random number generators, right? Like really difficult to say, are they accurate? Is it true? Do I believe this? Especially when you have a blue patient that's reading at 99%. And they're like, something's a little bit off here. What's it say?
It says wrong, lies.
It's so accurate. So the way that the pulse ox works, just a little bit of like background to this. It emits two wavelengths of light, 660 and 940. Looking at you, Cummings. 660 and 940. So the 660 is in the red wavelength, the 940 is in the infrared wavelength. Oxygenated hemoglobin, so oxyhemoglobin, absorbs the 660 wavelength and allows it absorbs the 660 and allows the 940 to pass through. And so what it's doing is the probe, the LED, which I should have known this, but that's a light emitting diode. I don't know if anybody else remembered that from,
That was today or.
right? Light emitting
What LED
diode.
stood for.
So anyway, it emits this light. And there's two different ones. The one that you put on the tongue is the one that it's like looking at the sensors on the other side of that tissue. Whereas if you have the flat faced one, it's a reflective. It's like asking for the reflection to come back and reading that. So it's measuring how much of that light is getting through and how much of it is getting absorbed. And that tells you, based on the proportion of how much of the 660 versus 940 is getting absorbed, how much of the oxygen, how much of the hemoglobin is bound to oxygen. That's what the pulse ox does. Now, you have to have a good wave because hemoglobin isn't the only thing that absorbs light. You've got all the other stuff in there. So that's what this is showing you. So other tissues, venous blood, non-pulsatile component of arterial blood. So this diode sensor is specifically looking at the pulsatile portion because that's going to be the arterial portion of the blood. And in systole, because there's more oxygenating blood coming through, there's going to be more wavelengths absorbed. And then in diastole, it's going to be less coming through, so less is absorbed. So the issue with pulse ox is one, it's very finicky. Two, it doesn't necessarily tell you if the oxygen is if the hemoglobin, the oxyhemoglobin that's there is actually a functional hemoglobin molecule, meaning you can have other forms of hemoglobin that have bound to things like carbon monoxide or now I've drawn a blank, but like all the other things like methemoglobin, there it is, like all of these different dyshemoglobins that the machine is still picking up on because they're still absorbing this wavelength of light, but it's not actually telling you that that is one that is oxygen bound to hemoglobin that is functional for the animal. So it can be falsely elevated or falsely decreased based on what other what else the hemoglobin has bound. And the other thing is, it doesn't tell you above 100% if the animal is still or how much oxygen is actually there. So for example, you can have an animal in a hyperoxic state that is above 100 that looks the exact same to the pulse ox. And we'll go into that a little bit more because it's not quite clear. Or not the easiest thing to get until we go into ARC gases. So before we do, how are we going to stabilize our lab friend? Please calm it down. You've given it some Torb, among other things. What else did you? It's still breathing like a nightmare. What else are we gonna do? Intubate it, right? All right, so we intubate it. We now know what our pulse ox does, so we're gonna attach a pulse ox to it, and the pulse ox is reading 80%. What else do we need to do? So what does intubating mean? Like, what are we actually doing when we're intubating an animal? Yeah, we're bypassing the upper airways, getting it directly into the trachea. Do we always give oxygen once we've intubated? Yeah, not necessarily. So in this case, pulse ox is reading 80. Okay, give it some oxygen. And in doing so, because you've taken away, so Because the pulse ox is still reading 80, despite having fixed this and despite having controlled the animal's respirations, the fact that the pulse ox is too low should clue you in that the lungs themselves are not working appropriately, right? Because you've gotten rid of the mechanical issue here. Now we have an issue with oxygen exchange. So we need to try to better clarify what's actually happening in the lungs, because we've said, okay, there's some limitations to our pulse ox. It's a good triage machine. It's a good one to show trends. It doesn't tell you all the information that you need to know. So Mary Beth, you said an art gas. All right, so what information can be gotten on an art gas? Before we go into that, just quickly, art gas is what we're usually feeling for is the dorsal pedal arteries. You could potentially hit any artery that you want and get our blood, arterial blood from it. So that includes like the tail, the femoral. You could hit the right atrium if you wanted, it just wouldn't be ideal. But you are looking for the dorsal pedal and the dorsal metatarsal artery. We're typically feeling for the second one, the second or third. So these two, as they kind of course through, most commonly it's that one. And the really important information that we're getting off of an art gas is your partial pressure of oxygen. So that's the amount of oxygen that's dissolved in the blood, the amount of carbon dioxide dissolved in the blood, and then how those two are influencing, specifically the carbon dioxide, how that's influencing the pH. And there's a couple of like portions of the pH that we're also looking at. So there's bicarb, which is the HCO3, and the base excess. They tell very similar things, but the bicarb can be slightly skewed, especially if you have changes in your carbon dioxide that's outside of the range, because I don't know whether I want to get into this. Carbon dioxide and bicarb form together, like push each other to want to ends of the spectrum for, okay, I'm not gonna get into it, doesn't matter. Anyway, bicarb is affected by carbon dioxide. Base excess is just the amount of base that you have in that system to get it back to its normal pH. So base excess actually takes out the respiratory component of the acid base. Not necessarily that critical, but we do actually need both of them to best interpret arterial gases. Now, what's important to note is that in a normal state, animals have can have above 100 of partial pressure of oxygen, even when they're breathing room air. So you should usually have somewhere between 80 to 100. I don't know this unit. Oh, millimeters per mercury. Stop. Millimeters of mercury of dissolved oxygen in your blood. And you can go above that. So like an animal on 100% oxygen with normal lungs should have above 500 millimeters of mercury of dissolved oxygen. So you can see that if you had a pulse ox, like where this becomes a little bit of an issue, because you're not getting to those really high levels of dissolved oxygen. Okay, so the question then becomes, how do we correlate what we're getting on the art gas to the pulse ox, right? Because those are our two kind of triage diagnostics, and they're supposed to tell us very okay, very similar things.
We're gonna ask them to send up the slides since they're backwards on this one listening.
Oh,
I like this chart.
They're backwards?
Repeat this chart.
oh yeah, it's a good chart.
I've tried to fix it.
I see. It's a reverse image.
Let's see.
I got you. Okay, so the way that we associate them is with something called the oxyhemoglobin dissociation curve. All right, it's pulse ox, your SpO2, that's the number, that's the percentage that you're getting, and your PaCO2, your partial pressure of oxygen, are directionally related. So they both go up, they both go down in the same direction, but they are not linearly related. So what that means is that for every unit increase in your pulse ox does not necessarily mean a unit increase in your partial pressure. It's your partial pressure. So remember I said that SpO2 is measuring how much oxygen is with the hemoglobin, right? So it's the oxyhemoglobin. Partial pressure of oxygen is actually the amount of dissolved oxygen that's in the bloodstream. So it's the stuff that's not attached to the hemoglobin inside the red cells. The partial pressure of oxygen is actually what determines whether oxygen is going to get dropped off in tissues or not. So what this graph tells us, it's got hemoglobin saturation on the y-axis and oxygen partial pressure on the x-axis. And if you have less oxygen dissolved in your bloodstream, that means that your tissues are probably needing oxygen. So you have less of that oxygen that's going to be bound to hemoglobin because all of that oxygen that's on the hemoglobin is now getting delivered and immediately kicked off into the tissues. And the opposite is true, that when you have a lot of oxygen dissolved and hanging out in your liquid component of your blood, then that means that your tissues probably have used up most of what they need and there's an excess amount. So hemoglobin is going to bind that oxygen more because it doesn't need to get delivered to the tissues because the tissues are already in excess of it. That's what the direction means. But there's this, it's called a sigmoid curve. So you can see that initially, as you have really low partial pressures of oxygen, it can come up on your hemoglobin saturation. So on your pulse ox, as actually quite high. So a partial pressure of oxygen at 40 is actually a pulse ox of 75. And we said that normal animals have a partial pressure of oxygen on room air somewhere between 80 to 100. So we know that if their partial pressure of oxygen is 40, and we're reading a pulse ox of 75, that's not normal. That dog or cat is hypoxemic, right? And so when we actually talk about animals that are hypoxemic, what that cutoff actually is a partial pressure of oxygen of 80, and severe hypoxemia is a partial pressure of oxygen of 60. And look at the difference on the pulse ox. A partial pressure of oxygen of 60 reads a pulse ox of 90%. Which most of us are like, oh yay, it's 90% in a respiratory dog, but actually that dog is in crisis. Same with a pulse ox of 95%. So usually we'll have a call parameter, if we remember to do that on instinct, that says, hey, check your pulse ox, it's 95%. That's when I need you to call me, because we know that that means that your dog's blood or your cat's blood is actually hypoxemic. There's some things that influence that. That's what's on this graph. Like, some things can shift the curve to the right, some can shift it to the left, meaning hemoglobin is more or less likely to hold on to the oxygen, a little bit less important, but it actually, where it becomes important is when we're looking at ARC gases. So temperature actually is pretty important when you're, especially in a febrile patient. But that's kind of the main takeaway. Hypoxemia, partial pressure less than 80, severe hypoxemia is a partial pressure less than 60. Now, where I was saying that the pulse ox doesn't tell you anything about hyperoxic states, it's because you can see this partial pressure can go all the way out to 500, 600. But that's a straight line out there. So for even greater increases in your partial pressure, well, your pulse ox is still reading 100. Yeah. Now, an aside about cyanosis. Cyanosis is always a late sign of hypoxemia, of severe hypoxemia. So there's some math in there, but what cyanosis means that your dissolved percentage bound percentage of oxygen is 67%, which reads at a PaO2 or on the ARC gas as 37 millimeters of oxygen. The other thing that's really important is cyanosis is actually about how much is bound hemoglobin. If you don't have a lot of hemoglobin, like an anemic animal, the animal will die of hypoxemia before you will ever see cyanosis on the gums. if you have a patient that presents in cyanosis, that should be an absolute clue. They need intubated if they are having inspiratory distress, and oxygen if they are having expiratory distress or paradoxical breathing. Great. All right. So we take Lady Gray's art gas. What are we noticing here? This is her intubated, not on oxygen. There's a lot of extraneous data in here. Yeah, she's hypoxemic at 78.9. And her carbon dioxide is a bit low. All right, so the question is, what does that actually mean? What are we looking for when we have an art gas? So what we're actually trying to do is we're trying to figure out why the animal is hypoxemic, because we can say Lady Gray obviously has a low partial pressure of oxygen, right? It's below 80. But that doesn't tell us why or what we need to do about it. So this is like the tree of hypoxemia. In the orange is what's the most important part. The red, this stuff, don't really worry about it. It's not something that we typically see in veterinary medicine. So there's two parts of this, two branches. The first is either you're hypoxemic because we're just not giving enough oxygen. So say, for example, you've intubated, you forgot to turn on the oxygen and your pulse ox is super low. Well, turn on the oxygen because you need to. The other is that you're not giving enough breaths, right? So you're hypoventilating and that's not bringing enough oxygen in. Those are two very easy things to see and to correct, right? What's the more difficult one is there actually an issue in the lung space itself? And this is where we come into play, right? So some fancy words that have always confused me. So we'll kind of step back for a second. This is these two like major branches, low inspired oxygen. We can fix that very easily. The oxygen cage is on or it's off, you know, but hypoventilation versus these others. So that's what this is. So this is the hypoventilation side. So basically the theory behind this is that partial pressure has to, like, it's 100%, right? So it has to make up 100%. So some of that has to be carbon dioxide, some of that has to be oxygen. If you have more carbon dioxide, you have less oxygen. And that's where the hypoventilation or increased carbon dioxide comes into this, right? That's that logic. We'll go into that in a second. This is the issues with the lungs themselves, and we call that perfusion versus ventilation. So VQ mismatch. So Q is perfusion, V is ventilation. And this diagram represents an idealized alveolus. And then these black circles represent where the problem is, so where things have stopped. So if it's an issue with the alveolus, so something is plugging the alveolus, that means that air is getting down here, oxygen is not getting down here, right? Because it's being stopped, but blood is perfusing that alveolus. But because no oxygen is in here, that blood is going to go straight back being non-oxygenated, right? That is a low VQ mismatch. So ventilation is 0, blood flow is 100. The other side of this is where the alveolus is getting oxygenated. So you're getting oxygen in there, but you're not getting any blood flow. So your blood is still staying deoxygenated, right? That's called a high VQ mismatch, where lots of ventilation, no perfusion. Now, we have a way to try to determine which one of these is being affected, or which one of these is playing a role. And that's by looking at the AA gradient. So how many times has somebody said we need an AA gradient? You know that? So. So that's what we're trying to find out when we do an AA gradient. We're trying to say that we know that this isn't due, that your hypoxemia is not due to hypoventilation because your AA gradient is high. That's what the AA gradient tells us. It eliminates the ventilation portion of the causes of hypoxemia. So that tells you, all right, if you're we know if the percentage of oxygen that's being delivered is low. We also know if they're not being ventilated based on the AA gradient. So the important one in there is the box in blue. The how this gets derived is based on the partial pressure of water minus the barometric pressure, and then FiO2 is how much oxygen is getting delivered. That all together at sea level and 100% oxygen, nope, 21% oxygen, excuse me, which is room air, is 150. That's why we use the number 150. And then 0.8 is the respiratory quotient, which doesn't really matter for the purposes of this conversation, but whenever we do this, like most of the time, the nurses will calculate 150 minus the carbon dioxide, partial pressure carbon dioxide that's on the AA gradient, divided by 0.8. A normal AA gradient should be less than 15. Anything above that is telling us that one of these issues is happening. And his is 49.9. Excellent. So we were going to calculate that, so thank you, ma'am. And now we have. But so basically what this will say is, all right, if your issue is due to an increase in carbon dioxide, your AA gradient is going to be normal. And if it's due to high altitude or low FiO2, it should also be normal. And so your AA gradient is only increased when you have those BQ mismatches like that. And then it'll also tell you if oxygen is going to improve things. So the only one that it won't improve is if you have like a PDA where your blood flow is going completely around the lungs and no oxygen is getting through. I know, bear with me. So if we were doing this and calculating this, then what we would do is we would take the PaCO2. So PaCO2 is 26.6. We would divide that by 0.8. And then we would subtract the number that we got there by 150. So, and this will give us the alveolar partial pressure of oxygen. So 78.9 divided by 0.8. I subtract that from 150. I get 51.37, like Mary Beth said. And now what we have to do is we take 51. I've messed something up here.
Yeah, I was like, that's not right.
No, I really have messed something up. Cummings.
Yeah, I got 38.
I got 38 when I initially did it, and now I got like -21.
I got,
Well,
I'm gonna get 49.
this is very embarrassing, guys.
37.
Oh,
She used.
because I used oxygen.
And see.
I used the partial pressure of oxygen.
Okay, you're right, Connie. 37.85.
You're right. Well, this was an embarrassing example of why you always check with other people. So what I was doing is I was using the partial pressure of oxygen instead of the partial pressure of carbon dioxide. So you do 26.6 divided by
That's why you
0.8.
have your text do it.
That is why we have our text do it, exactly. I become very spoiled.
Flash across the screen.
And then you minus 78.9, and that's 37.85 or 38. Did that make sense? Because I just completely bungled it for everybody. It's not that bad. Okay, great.
No, it'd be good.
Okay, great.
Mine
Thank
are
you,
the
guys. Oh, thank you.
They're like AA is like we see
Correct.
in sixties.
We see them much worse. But it is high enough that we know that there is true hypoxemia going on. So we should supplement oxygen. So then the next thing we could do is supplement oxygen and recheck what our whether or not that's appropriate. But once we supplement oxygen, you can't use the AA gradient anymore. Because carbon dioxide messes things up. So you have to use something called the PF ratio. So if you have an animal on oxygen, I know most of the time we're like, get it off oxygen. But even if you get it on oxygen, we can use this ratio, which takes the PaO2, so that 167.7, and divides it by the amount of oxygen that you're providing. This is the FiO2. This is what we're doing with the high flow. Now, it can be kind of a difficult thing to estimate FiO2 when you're on nasal lines. Like when you're in the oxygen kennel, if you're putting it on 40%, then the FiO2 is 0.4. Because it's always like divided by 100. But if you're using nasal lines, it's much more difficult. So there was actually a study done in 2002 by Dunphy et al. That basically measured the partial pressure of oxygen in animals with unilateral nasal lines, bilateral nasal lines, and then how much was actually being, like what the tracheal oxygen was for these animals. And so this is the paper that I use when an animal is on nasal lines. You have to do some math to convert it from mils per kg per minute to liters per minute, which is how much we're giving. But basically, if we were putting Lady Gray on 3 liters per minute bilateral nasal lines, that's this. It actually equals 75 mils per kg per minute in like a 25 kg dog. And so you could see that this is the second line is the bilateral nasal lines. It's just above 0.4 FiO2. So you could take 167 divided by 0.4, and you would come up with a PF ratio of 419. Right? So that's actually, we know that in like room air, normal dogs are 100. So that's an animal that is getting enough oxygen. Okay? And we use this mostly as a way to say, how bad is your lung disease? Because there's some criteria in humans that tell us about acute lung injury versus acute respiratory distress syndrome. And it uses PF ratios to do kind of grades of distress. So a PF ratio of less than 300 on oxygen is terrible. And then it's considered vet acute lung injury if it's less than 300. And then vet ARDS, which is a worse thing if it's less than 200. So that's basically what the PF ratio is saying. It's like, is the animal oxygenating well enough?
When they're on the high flow, and like we get this PF ratio, and they're in the 400s, or I'm sorry, if they're above 300, is that your indication that you can start to take in?
That's
I was wondering this.
it's based on that. It's based on the trend, like are they getting better, are they getting worse? And it's based on clinically, how are they actually breathing? Like if they're working super hard to get that 300, even though they're above 300, I'm still going to keep them on it. And I'm going to give them the benefit of the doubt that they still need it for a period of time before I start drawing them off. But oxygen toxicity does happen, and oxygen toxicity leads to fibrosis of the lungs over time. So having too much oxygen is also an issue.
That what we talked about the 100% renewable.
Correct. Yeah, so like you want to start getting your oxygen to like 60 to 80% pretty quickly. But then you can maintain them enough that for a while. So this was what Lady Gray's lungs would have looked like if we had taken x-rays and she were a real dog. We would have seen this very dilated esophagus that's right there, because she is a large part probably with my mega esophagus, because it's not just that the larynx gets paralyzed, it's that all of these muscles get paralyzed. And then you can see this kind of alveolar pattern in the right middle of the lobe as well. last one really quickly, Pipsqueak. It's a 4-year-old male neutered beagle, got into muscle relaxants and is presenting for acute lethargy. All right. Physical examining this dog. He's tachycardic. Otherwise kind of unremarkable. Put a pulse ox on him and it's 89%. He is not in respiratory distress. What should we do? Okay, sure. So we could give him an naloxone to see if it's some sort of an opioid related drug issue. Most muscle relaxers though are I feel like either inhibitory, like pro-inhibitory, or they block calcium.
He's gonna need a ventilator at some point because of his
Okay, why?
diaphragm, right?
Okay, so delve into that a little bit more.
Well, the diaphragm is a muscle and he's in muscle relaxers, and so he's got muscle relaxer toxicity. And he can't move air, and as long as if his diaphragm is becoming too relaxed.
There it is.
He's too lethargic and sedate from him.
There it is. Okay, so muscle relaxers, all of the, going back to the mechanics of breathing, it all is based on contraction of muscles. If you can't contract your muscles, you can't breathe. So I heard something else. How are we going to prove this, that the hypoxemia is related to an issue with our muscles? What should we do? Pulse ox is already telling us it's something's wrong. Arc gas. All right, remember, the arc gas tells us not only about the oxygen component, which is what the pulse ox is also telling us, but it also tells us about our carbon dioxide component. So this dog's PCO2 is 96.2. And if we were to do an AA gradient on this, we would actually see that it's in the negative numbers. So it's like very normal to excessively normal. Which tells us that it can't be any issue with the lung oxygenating ability itself, right? That's those like all the VQ reasons for mismatch. Clearly this dog is hypercapnic, so elevated carbon dioxide, because he is hypoventilating because he cannot move his muscles. So how do we fix it? How do we get an animal that isn't moving his muscles to move his muscles so that he can clear out this carbon dioxide? This is a prime example and one of the best reasons to ventilate an animal, because you put them on the ventilator. One, you also have to intubate to protect their airways because they can aspirate really quickly. But you put them on the ventilator, you let the baclofen toxicity do its thing, you give it some lipids, and within 1 to 5 days, they're off the ventilator, provided they haven't gotten any ventilator-associated pneumonias, and they're perfectly fine. And I forget what I named this dog. Pipsqueak is back to eating the baclofen. So
Back to eating more.
really quickly, you choose your oxygen delivery strategies based on your patient, right? So we clearly the least invasive is putting them into an oxygen kennel. This is a cat that wanted to bite us all. You can then also give them nasal lines. That's the next kind of level up. Nasal lines provide a limited amount of flow before it starts causing lesions in the airways because it's really dry and high focus. So then you can move to high flow, which provides humidified air at high rates, and you can titrate the amount of oxygen in there so that you're not at 100% the entire time, because you could potentially get up to 100% in the airways. And you don't want to lead to oxygen toxicity. And then in animals where even that's not enough, either because their airways aren't able to open well enough or they're not ventilating well enough, that's when we pull out the vent. And we use the ARC gas as a way to decide which of these we need, when we need to escalate, and when we can de-escalate. Those are my sources. That's a larynx. Any questions I can answer for y'all?
Do you guys have any questions online? You can unmute yourself. There's only like a few people left.
That's fair.
Well, there's only one person that left, actually.
Okay, also cool.
Just Mallory. She said, I know this stuff.
What an ass.
Sour well trained.
Well, she, uh-oh. All right, well, thank you all so much. I appreciate you.
Thank you. And then I have you guys all online, I have you guys all for attendance. Casey and Jack and Jen and Casey, and of course Jim. But can you guys send me all your license numbers so that I can put those in my attendance as well? But I'll email you. And you should be all set. Oh, wait, is there another question? Hold on. One new. Nope. All right, we should be all set. Thank you, guys. Sorry it was backwards. I tried.
They don't give us back to it. I was like, hey, can you give this to Bailin?